If you flip back, let me flip back a couple of pages. I sort of skipped over. Go back to the P4. You'll see that gives you 4 different pain rating scales. They're all 0 to 10. But I was talking about the idea of looking at pain over different periods of time. You'll see this one gives you the patient rates pain in the morning, pain in the afternoon, pain in the evening, pain with activity. Now again, the 10 anchor isn't my favorite anchor, as you all appreciate. But you may want to look at this and see sort of where their pain is changing. When this tool was designed and described, it was intended that you would take an average of the pain ratings. Okay, so you take an average of all 4, still get a score of 10. I am going to suggest that unless you're using this for research purposes, as clinicians, if you were to use a scale like this, don't take an average. Look at the individual scores. Otherwise, you risk missing change on one of those, right? So if over time, let's say somebody's pain in the morning dramatically increased, but their pain in the afternoon dramatically decreased, the average score is still going to be the same. But you would have missed that if all you were looking at was the average, okay? So I encourage you to look at individual ones. I give you the P4. It's, truth be told, I haven't found evidence that it's superior to the 0 to 10, just a single numeric rating scale, but it just gives you an idea or a sense of ways that you can measure pain over different parts of the day. And again, you can ask about pain over the past 2 weeks. Normally, what I ask, personally, is pain right now, sitting here in front of me, where are you? What's your pain been at its worst over the past 48 hours and at its best over the past 48 hours? Okay, those are usually the 3 that I ask. And then that leads into when it was at its worst, what were you doing? What did you do about it? That sort of thing. When it was at its best, what were you doing? How did you get there? Okay, so we can, again, all of these tools are meant to lead into additional questions. If you turn the page over one more then, from the P4 to, you'll have a little thing there that will have some faces on it. That's a tool, and I actually grabbed this at a booth, some pharmaceutical company's booth years ago. But what you'll see there is a number of different options for a pain rating scale. In color, the top one, the thermometer, is actually kind of goes from white to red. There's a couple of descriptors, verbal descriptors there. There's some numbers there. There's some faces there. The idea here is that sometimes patients have a hard time with, say, giving a number on their pain. It's just, for whatever reason, it's too ambiguous. Some people just don't think, in numbers. But they might be better off looking at the colors, as like a thermometer, or they might be better off using something like the faces. Now, the reason I put this in here is because this is what's called the Wong-Baker Faces Scale. One of the, I think, as far as I know, I think it was the first, or at least one of the first, standardized face rating scales for pain intensity. And the faces scales are thought to be more appropriate for your cognitively impaired individuals, for pediatrics, okay, for people who have a hard time communicating, is to look at the faces. There are now at least 3 or 4 different standardized face rating scales. The reason I want to put this one in here, though, is, again, it goes back to know what the tool is that you're using. If you look at this faces scale, for someone to score a 0 on that scale, not only do they have to not have pain, but they have to be, like, stupidly happy. Right? To score a 10, I think is what they're giving, or a 5, sorry, on that scale, they have to be crying. And there's one of the criticisms about the scale is that there's definitely some cultural bias there. In some cultures, as an example, it might be inappropriate for a male to cry in front of a female or a male sort of thing. So the Wong-Baker Faces Scale is probably, if you ever use it, is really only appropriate for pediatrics, to ask them to sort of point to a number, or point to a face, I'm sorry. There are other ones out there, and you can look at them. You can Google faces rating scales, and you'll get all sorts of them if you wanted to use one. But again, I would only encourage using those in cognitively impaired or really young or really old populations. And there's a series of tools that you can look at. Or sorry, there's a series of research you can look at to find what's the meaningful score here. Finally, I want to show you a couple of neat ideas for sort of hybrid type scales. So this is one, the iconic pain assessment tool. I don't know if anyone's seen this before, but so this one here, you choose male or female. Now, in this one, it's giving just front or back, but what we can do is we can take and say, yeah, I've got lacerating pain, and it's there. Oops. Hold on. How do I do it? Oh, it's not working. It's a little funny. Okay. Another one here. Oh, there we go. So I go back and I click and I say, yeah, I've got lacerating pain here. Oh, look, I can increase the hand size if I want. Say, yeah, I got some aching pain, whatever here. Oh boy, working brilliantly. Okay. So you can get an idea there. You can choose. So this is kind of a body diagram and qualitative scale kind of tied into one. Plus you've got morning, afternoon, evening, and overnight. Once they're done, if they were going to use this, they can go ahead and print that scale, and it'll actually give them a nice little PDF printout, and they can bring it into the clinic. Simple little tool there. And then there's another one that the same group worked on. I think it's meant to be perhaps a bit of an evolution. It's the pain quilt tool. Here we go. So again, I'll choose male. So here what we can see is already the hands and feet are expanded. We've got left and right sides at least of the head. What we don't have here are the ability to do morning, afternoon, evening, and overnight. A fair number of additional descriptors here. And now, what you see here is when I click on heavy, a pain rating scale pops up. And so I have, 6 out of 10 heavy pain, whatever that means. And there we go. There we go. Okay. Anyway, so you can do that. You can even choose another. There's another option here. Dull, sharp, that kind of thing. And so again, I can see right on the body diagram here where the patient's experiencing their pain and the intensity of the pain in that area, plus the quality of it. So these kind of hybrid scales. My understanding is they continue to work on these because both of them are useful in their own way. None of them are quite perfect yet, but I think they've really got some utility there.
How many options do you think are ideal? Because this one seems like it almost has too many for the description, like shooting, electrical. It might be difficult to differentiate between a few of them. The last one seemed to be more direct, like 6.
Yeah, I would agree, and it's an interesting question, right? How many options are too many options? Mm-hmm. Sometimes patients just get lost. I don't know which one of these I should be choosing. What do you want me to say? Is this shooting or is it stabbing or burning? I'm not sure, right? So absolutely, like I say, it's not perfect. Some people really appreciate this, others not so much. It's a different tool that you can use. The nice thing here is it's something they can do at home, print out and bring back to them. So if they are able to understand this, you hope that people don't have a ton of these different experiences, but maybe they will, and they'll bring it back in. I tried creating a smartphone sort of app for this sort of thing a while ago, but I got bored and stopped. Anyway, so a couple of different options here for these scales that at least they incorporate a lot of different aspects of that experience into one tool. So if you haven't seen those, keep an eye on them. They'll pop up from time to time. So to summarize this, and I've made this part mercifully short, capturing other aspects of this experience often is going to provide you more guidance than just pain intensity alone. You think about quality. So if my patient endorses things like cold, tingling, maybe burning, itching, shocking pain, all of these are things that make me go, looks like possibly a neuropathic component to this experience. And that's going to necessarily change the way that I approach treatment versus if they said, sharp and localized, maybe dull, achy, things like that. Okay. So it can give you a little bit more information on the nature of the pain experience. Most of them are relatively easy. I will say those quality tools do tend to take a little bit more time, right? There's more options there, so just be prepared if you're going to use one of those. And right back to this idea of triangulation. Gives you a little bit more ability now to try and pinpoint where that sort of experience is lying. So you've got intensity, you've got quality, you've got frequency, you've got location. And location might be as simple as localized or diffuse. Even that gives you information around the potential mechanisms here. Any questions around any of those tools? This is the first time we've actually looked at some specific tools here. All right, here's one of my favorite questions, actually. In meta-analysis and systematic reviews, we use pain as one of our primary outcomes. What does this mean? And since I never pass up an opportunity to toot my own horn, so I actually asked just this question a few years back, 2009, looking at the most common types of outcomes that are predicted in prognostic studies. In other words, the question is, what are we trying to predict? What's important? And certainly most commonly, the number one is pain intensity. We're trying to predict pain intensity. Here's an interesting little question for you. If I'm trying to predict pain intensity, what do you think is the best predictor of pain intensity? Pain intensity. If I was trying to predict neck disability index score, what do you think is the best predictor of NDI score? NDI score at baseline. Choose your outcome. The best predictor of that outcome is going to be the same thing at baseline. That's consistent. So when I say pain intensity is the most consistent predictor of outcome, certainly in acute WOD, and I think in low back pain as well, that's because most of the time people are trying to predict pain intensity. That's the outcome that they're using. And if you want to understand why this makes sense, this is a quick lesson here for you. If I've got baseline score and let's say 3-month score, and I've got two people, one who starts at 4 out of 10, and one who starts at 8 out of 10. And before I do this study, I decide that a score of 2 out of 10 or below indicates a good outcome. If both of these patients improve by 3 points, that guy recovered, that guy didn't. The way the analyses and statistics work on this is normally in a nutshell what's happening. And so clearly, the best predictor of your outcome is going to be the same outcome at baseline. So anyway, I just see that in mind. There's probably not a whole lot of clinical relevance to that. It's more of a research question, but just something to keep in mind. Okay. And sorry, I guess there was a second part to that question. What does it mean? Yeah, it means that you can always predict an outcome by virtue of knowing the outcome at baseline. You can predict work status. Definitely the best predictor of work status at outcome is work status at baseline. But another interesting way of predicting work status is asking the person if they expect to be back at work after 3 months or whenever you're going to collect your outcome. That seems to be quite effective as well. Interesting. Question. So in an ideal situation, would you like to use SLANs and pain detect forms to help triangulate towards a neuropathic component, or is one sufficient? Wow, interesting. Interesting idea there. If I really wanted to be as confident as possible that this has a neuropathic component to this pain, because, for example, I thought the next step is going to be referred to a specialist clinic, maybe an EMG or something like that, and I know not everybody likes EMG, nerve conduction studies, and I really wanted to be fairly confident, or I wanted to make some comment about this to a third-party provider, then there's no reason why I may not decide to use both. Why not use both? And if they both state, yes, there appears to be a problem here, then that's giving me that more sort of triangulation, right? It's giving me more confidence that the condition exists. I don't think you need to do that. I think the evidence is probably good enough that you could use, say, just the SLANs, which is the one that I prefer just because it's simpler, frankly, and say that, the evidence, in fact, you can cite the evidence. So it said that, a score of 12 or higher, this person's scoring 15, strongly suggestive of pain of primarily neuropathic origin. And that's probably good enough. But if for some reason you really wanted to be confident, there's no reason you couldn't use more than one of those. Verbal rating scales, what do I think of verbal rating scales? They're fine. I have no strong opinion one way or the other on verbal rating scales. The full McGill has a bit of a verbal rating scale, even the short form McGill has a verbal rating scale. For some people who have a hard time choosing a number, again, that can be a little bit abstract, putting words on there might help them a little bit. In fact, I'm going to show you a scale that I use for cold intensity rating that is a hybrid of number thermometer color, and verbal rating. So it seems that way kind of covers all the bases. Okay, so that's that.